afternoon and welcome to the Medical College of Wisconsin's Coffee Conversations with Scientists. I'm your host, Raina Andrews, and for those of you tuning in for the first time, let me introduce myself. I am a mother, a children's book author, a public health advocate, and an engaged community member. I'm your host for the 2023 Coffee Conversations with Scientists series. Coffee Conversations is brought to you by the Advancing a Healthier Wisconsin Endowment, a statewide nonprofit working to improve health and advance health equity in Wisconsin. Since early in 2021, we have been sharing the science behind today's most important health topics. Now, today, we are covering a very timely topic. As May is Women's Healthcare Month, we thought it was important to shed light on some of the pressing matters impacting women's health. There are stark racial disparities in maternal and infant health across the United States, and particularly here in Wisconsin. The real disparate impact of the COVID-19 pandemic for people of color has brought a new focus to health disparities, including the longstanding inequities in maternal and infant health. Recently, there has been increased attention and focus on improving maternal and infant health and reducing disparities in these areas, including a range of efforts at the federal level. Today, we'll explore new research that helps explain the rising disparities and risks in maternal health. So today, we have a very special guest, Dr. Anna Palatnik, with the Medical College of Wisconsin. Dr. Palatnik, welcome.
Thank you, Rihanna. It's great to be here.
Wonderful. So folks out there in the interwebs, we'll be covering a great list of questions on the trends, facts, and misconceptions associated with the state of maternal health and possibly explain what's causing these disparities. I encourage all of you watching to drop any questions you have on the topic into the comments section. We'll be getting to as many questions as possible. All right, so let's get started. So, Dr. Palatnik, I think you are a phenomenal resource in just agent of change, and we're so lucky to have you today. My first question for you is, what do you do as a maternal fetal health medicine physician? What do you do? What is that?
Thank you for this question. So first, I will explain what does it mean, maternal fetal medicine physician. It means that I'm an OBGYN who is trained in management of high-risk pregnancies. The pregnancy can be high risk when a pregnant individual has a medical complication before or during pregnancy, or when the fetus has a high-risk condition requiring close surveillance during pregnancy and after birth. And specifically here at the Medical College of Wisconsin, I do both clinical work. I see patients in clinic. I deliver patients on labor delivery that have high-risk pregnancies. I do procedures like putting cerclages to prevent preterm birth. And also I do research, mainly clinical research.
Mm-hmm. Well, tell us a bit about your research. And I think it's important to distinguish that you're not only a practitioner in the space where you have patients that you see, but you also research this. So you're addressing the issue that's at hand, but also looking at upstream. So tell us just a little bit about some of the research that you do and that you've done.
Yes, so it's my research is primarily clinical. It involves pregnant people, pregnant and birthing people, with a focus on a few conditions such as gestational diabetes and preeclampsia, or what is known as hypertensive disorders of pregnancy. I study clinical interventions to improve management of gestational diabetes and also ways to reduce the risk of heart disease following pregnancy complicated by preeclampsia. And I also work with community organizations to develop interventions to reduce health disparities in maternal health.
Got it. And so in my opening statement, I shared that the terms, the buzzwords of maternal health and high-risk pregnancy, this has been a growing issue over the decades. And we often hear these terms thrown around. So for the context of our conversation of speaking maternal health in the context of high-risk pregnancy, how should we be defining this? How should we frame it for our conversation today?
Yes, that's a very good point, Anna. So maternal health includes health before pregnancy, or what we call preconception period, and health during pregnancy, during childbirth, and after giving birth in the postpartum period. A lot of progress has been made in improving maternal health, but still many women start pregnancy with suboptimal health, and many experience complications, both medical complications and obstetric complications in pregnancy and in childbirth. So when we talk about maternal health, we need to talk about two terms of, one term is maternal morbidity and one term of maternal mortality. Maternal mortality or pregnancy-related death, defined as death during pregnancy or within 1 year of the end of pregnancy from any cause related or aggravated by the pregnancy. But this is just the tip of the iceberg, as many more women suffer from morbidity and disability following childbirth, which impacts their overall health. We don't know the true extent of maternal morbidity, but it has been suggested that for each maternal death, 30 and even more women will have maternal morbidity. And when we say maternal morbidity, we refer to any health condition attributed to pregnancy or complicating pregnancy and childbirth that has a negative impact on women's well-being. And specifically in the US, there are significant disparities in maternal morbidity and mortality, as we can show you right now in a graph. Perhaps we have some technical difficulties.
So if you can speak to the graph that's on your screen, the blue one, I think the people out in Facebook world can see it.
Great. Yes. So this graph shows rates of maternal mortality in the US. It looks at the years of 2014 and 2017, and it shows the number of deaths per 100,000 live births. And in this graph, we see that pregnancy-related mortality is elevated among American Indian and Alaska Native, Asian Pacific Islanders, and for certain subgroups of Hispanic women, including Puerto Ricans in specific region within the US. And also you can see that non-Hispanic Black women, they have had the fastest rate of increase in maternal death since about 2007.
Wow.
You can see the disparity that non-Hispanic Black, the graph on the left, has the highest rates of pregnancy-related death.
So in this context, we're really talking about with high-risk pregnancies, those with preeclampsia, preterm birth, gestational diabetes, those three main factors of high risk. Now let's talk about why are there such stark disparities between Black women and white women with high-risk pregnancy when we talk about morbidity?
Yes, so disparities in maternal health and morbidity and mortality, they're complex, and they are a result, we think, of numerous factors. Numerous factors including social, environmental, biological, behavioral, as well as healthcare factors. This topic has been studied by several leaders in the field of maternal fetal medicine and in other fields, and the leading notion is that disparities are due to a combination of factors. So we look at patient factors such as socioeconomic status, race and ethnicity, certain behaviors, overall health before pregnancy. Then we look at the community and neighborhood factors, such as is there or there's lack of social networks, how good is the built environment, access to stable housing. And we also have provider factors, provider knowledge, implicit bias, how good their communication skills, and system factors, such as does a patient have access to high quality care, structural barriers, structural racism, and certain social and political policies. And the combination of these factors results in a maternal health status that we have right now, such as presence of chronic illness before pregnancy, and also pregnancy complications, which may or may not lead to maternal morbidity and mortality.
So just to be clear, what we're talking about here is not just women going full term with their pregnancies, like women not giving birth and not making it out of the birthing room.
Right, right.
That's alarming. Yes. Let's talk about the role that income plays in this. How does income affect this disparity?
This is an interesting question. Initially, many of the health disparities in maternal health were attributed to low socioeconomic status. When a mother has to worry about day-to-day expenses and income and basic daily needs, attending routine prenatal visits or taking medications regularly cannot be prioritized. But it is important to note that disparities go beyond class. We have one more graph to show with our listeners, and in that graph, you can see that even in patients that have high education, there are disparities in mortality by race and ethnicity. In this graph, pregnancy-related mortality ratios are presented by education attainment, and disparities persist even in the highest education group on the right, college graduate or higher, with Black women being more than 5 times more likely to die from pregnancy-related cause as compared to a white woman with a college education. So it's definitely goes beyond income, and it goes into other factors.
You know, this is disturbing, Dr. Palatnik. If I could be so transparent, I am a mother, like I mentioned in my introduction, of a 5-year-old brilliant little boy. But I mean, I'm educated. I have 2 masters. I have the means to take care of myself, my child. And I was considered at the age of 35 when I had my son to be a high risk pregnancy. And I was not clear on why that is, because I had all the tools. I had a doula. And so I could speak up for myself and advocate for myself. So I'm not understanding why even I would be at high risk. Is it just because I'm a Black woman?
So based on what you're describing, they probably use the age factor. So anyone who's 35 and older, it's one of the criteria for being a high-risk pregnancies, more so for high risk of fetal complications, high risk of genetic problems, birth defects, but also with age, there's more complications with maternal health as well, high risk of diabetes, hypertension. So all that factors why patients would be high risk at the age of 35 and beyond.
So the less economic means, the higher risk. But what you're saying is that they used to think that income used to be a big driver, but now it's not as absolute.
Exactly. It's not an absolute. It's not.
So what impact does diet have on maternal health outcomes?
I'm passionate about diet and lifestyle, but I have to tell you that diet has been understudied in maternal health. In my opinion, this is a health factor that can be modified and potentially improve maternal and fetal health. Preconception or before pregnancy access to healthy diet can reduce hypertension and obesity. And during pregnancy, it's important to follow recommendations of how much weight a pregnant patient should gain, or what we call gestational weight gain. And adhering to these recommendations can help reduce the risk of gestational diabetes. Diet also plays an important role postpartum. Diet, especially in patients that have hypertensive disorders of pregnancy, preeclampsia, or gestational diabetes, by keeping a good diet, reducing intake of processed food that contain high level of saturated fat, sugar, and salt, women can, I believe, at least partially reverse the trajectory of long-term cardiovascular disease.
I think gestational diabetes, people get that gestational diabetes is diabetes while you're pregnant. Preeclampsia is more of becoming hypertensive while you're pregnant, correct? And so are there indicators prior to, like, can you not have diabetes or not have hypertension prior to getting pregnant, but develop that while you're pregnant?
Yeah, that's a very interesting question. Some women have predisposing risk factors, for example, carrying extra weight before pregnancy or having, a kidney disease. Does increase the risk of hypertension and diabetes in pregnancy, but some women don't have that many apparent risk factors. We try to identify patients that have risk factors, for example, for preeclampsia, and if patients have these risk factors, we have one strategy to reduce the risk of giving patients low-dose aspirin, which is safe in pregnancy and can reduce the risk of preeclampsia. But we still need to do research in this area. That's the only intervention we have to reduce preeclampsia today, baby aspirin. There's nothing else really that has been shown that is working.
And you mentioned that obesity, like being overweight, is really a culprit and a gateway for a number of these chronic diet-related diseases.
Exactly. Yes.
What is the appropriate amount of weight that someone could or should gain during pregnancy?
Yeah, so it depends on the starting body mass index, but for a normal weight patient, the recommended weight gain is between 25 and 35 pounds. And then we reduce it if a patient starts pregnancy overweight with BMI of 30, then we recommend between 11 and 20 pounds weight gain in pregnancy.
Okay. So I remember when I was pregnant with my son, I was very particular about what I ate, because I know what I ate is what he eats or he consumes in some way. And so I was very diligent, but there are some times where I just wanted a sundae and you have these cravings. And I was very meticulous about not going overboard and using me being pregnant as a license to eat everything in sight. So with that, I do have another question for you, and it's particularly around this disparity. You shared some really stark realities with the first graph that you showed, the blue and white one. And it just makes me think this is a huge problem where women are dying. Pregnant women are dying. They're not making it even to the delivery room. I'm just wondering what advancements are being made to truly address some of these disparities.
Yeah, that's a very important topic. There are advancements. So many professional organizations, including our Organization of American College of OBGYNs and Society of Maternal Fetal Medicine, and other health organizations, promote policies to reduce maternal health disparities. For example, one policy is for each state to have perinatal quality collaborative, or what we call PQC. It's a multi-state network of teams working to improve quality of care for mothers and babies. They identify where we can improve and how quickly we can make this change. In addition, each state has maternal mortality review committee, and we recommend to report these mortality cases by race and ethnicity. Many states expanded Medicaid coverage through 12 months postpartum. We are working on this for Wisconsin. Currently, the coverage is only for 60 days postpartum. Specifically at the Medical College of Wisconsin and Froedtert Birth Center, where I work, healthcare providers undergo education on racial and ethnic disparities in maternal outcomes, the importance of shared decision-making with patients, the importance of training in implicit bias, being aware of your implicit bias, education about how to communicate effectively with patients. We also implemented a disparity dashboard, which stratifies quality metrics by race and ethnicity. Important to say, we're also partnering with community organizations. You mentioned, Rihanna, that you had a doula to support your labor, but not every woman has access to doula. In Wisconsin and many other states, doula services are not covered. And also many doulas, there's not enough doulas. So we are working with community organizations such as African American Breastfeeding Network here in Milwaukee, and Wisconsin Collective Doulas of Color, helping train their doulas, and by this way to diversify our perinatal workforce and to have doula support throughout prenatal care and postpartum. In addition, we implemented protocols and checklists. We want to standardize care on labor and delivery, so each patient gets the same care, because when there's no guidelines, then there's room for bias. Another important thing that I strongly advocated for is to add postpartum remote monitoring, especially for patients that had preeclampsia or hypertensive disorders of pregnancy. Patients go home, and many of them have complications the first 2 weeks postpartum. They can have severe range blood pressure, they can have stroke, and this is the time when they don't have such an intense follow-up as they had when they were pregnant. And especially for patients who come to deliver here and live in a rural area. So having this remote monitoring, having a blood pressure cuff at home that is being monitored by our team here is a very important step in improving postpartum care. And beyond Wisconsin, other things that are being done in the U.S. are, for example, there is a model of group prenatal care. It's being done in a few hospitals here in Milwaukee. Having something called maternal medical home, which is a care coordination by a nurse and a social worker that also provides home visits, and it provides financial incentive for healthcare organizations for participation in achieving, for example, a vaginal birth. So the hospital can get a higher incentive if a patient has a vaginal birth. Other initiatives include patient navigation postpartum, in general, increasing access to mobile health technologies that provide also patient education and support. And last one I will mention, I'm sure there are more that I didn't mention, but last one I will mention that developing pipelines for increasing diversity, both in clinical side among physician, nurses, and also in researchers and people who do research in maternal health. We know that diverse teams perform better, they learn from each other. So that's another initiative we're working on.
You said it's not an exhausting list, but that is a lot to hear. And I'm really encouraged to hear that there's so many advancements happening at once. And I'm really curious, outside of the institution, how community is really maybe being sought after to provide a voice in this and to maybe advise with some of these advancements.
Yeah, this is something here we're actively working on, not to work in silo in our academic hospital, academic university, but to partner with communities, partner with community organizations who take care both of pregnant patients, but also reproductive age patients who may become pregnant, and to provide more education. We have a few of my colleagues going to high school and universities to provide education about healthy diet, access to birth control, and in general the concept of planning pregnancy before pregnancy starts.
Right, right.
So yeah, definitely we're always looking for more community partners.
This is very encouraging. So I see we have some activity in the chat. So I'm going to ask my last two questions and we're going to open it up to our audience. Okay. So my question is a bit controversial, Dr. Palatnik, but with the overturn of Roe v. Wade, how does this barrier to abortion, particularly for people of color, widen the already existing large disparities in maternal and infant health?
So just like you said, there's already a wide gap. People of color face more barriers to accessing healthcare in general, and now they have more limited access to coverage for abortion. They may have more limited financial resources and may face other increased barriers to accessing abortion, especially when they need to travel now out of state. And also, many of the states that restricted or banned abortions, they do not have the needed infrastructure to support the parents and children. A recent study showed that mothers and children in states with the toughest abortion restrictions tend to have less access to healthcare and financial assistance, which ultimately leads to worse outcomes.
So with that, I do have kind of like a rapid round question, but I want to turn to our audience. I see they're pretty active in the chat here. The first question is, does prenatal and maternal mental health play a role in maternal morbidity? I'll ask that again. Does prenatal or maternal mental health play a role in maternal morbidity?
Yeah, thank you for asking this question. I actually did not address it in these questions, but it has been on my mind. It definitely plays a role. We know that maternal mental health is associated with many adverse outcomes, at high risk of preterm birth, actually high risk even of gestational hypertension, and it can be depression, it can be anxiety and other mental health problems, and especially before pregnancy, patients don't have good enough access to mental health providers. That can even worsen outcomes for these patients.
Mm-hmm. In your question in my question of advancements and what's being done, you mentioned access to doulas. And one of the questions from our audience is, what role or how can doulas really help with these disparities?
It's a good question. There is research showing that doulas help improve communication, and they're being an extra voice advocating for the patient. And they help, what we say, diversify the perinatal workforce. And I think that's an important link. Right now, doulas operate most of the time in parallel to healthcare providers. So patient sees doula separately, and then the patient sees the healthcare providers. I think the ultimate goal to improve this collaboration is to have doulas be more integrated in the prenatal care, meet the provider ahead of time, so that I think that improves trust among all three partners, patient, provider, and the doula. Improve communication, and communication, we know it's a big piece of what's happening on labor and delivery and birth outcomes.
Mm-hmm. So I think you kind of touched on it, but the follow-up question to that is, how is the work of a doula coordinated with the OB team?
Yeah, exactly. So I think we need to work on improving that coordination.
Mm-hmm.
In my ideal vision for that, and we just applied for a grant to develop a model like that together with a community partner, the African American Breastfeeding Network. we applied to create a model where doula works very closely with obstetric providers, where all providers in labor and delivery, nurses, residents, students, aware of the benefits of doula. So educate both the providers and the trainees here in the healthcare system about the benefits of doulas, and also introduce doulas earlier to prenatal care. So once all parties know each other and feel comfortable with each other, patients will get better care.
I could say for me, it's like I knew nothing about birthing a baby. And so right away, when I learned that I was pregnant, I did get a doula. And to your point, not only opening up communication, but also managing expectations. I need to have a birthing plan. What's a birthing plan? Going through this questionnaire, what my wishes were. And, even after I gave birth, like, do I plan on breastfeeding, getting prepared for that? And so I'm so encouraged that you've written this grant and opened up the opportunity to connect those really key pieces in support of the patient's overall health. Two more questions. We have way more, but we have time for two more questions. Does standardized maternity care actually improve outcomes?
That's such a good question. So when I started medicine, I looked at that as art. There's an art of medicine. Everyone needs an individual approach. And yes, there is a rule, but you still need to see the patient in front of you and decide what's best for her. And I still think there is room for that. But I think in this day and age, with such terrible disparities and biases, I think at this today we do need standardized guidelines. We need standardized guidelines so that every patient gets the same care, the same high quality of care. And once we eliminate the disparities, then we can, I think, shift back to art of medicine.
Mm-hmm. And in that question of standardized maternity care and asking, does it actually improve? Their assumption was that individualized care would lead to better outcomes for pregnant and laboring people. Is that a correct assumption?
I would say it's a combination. Of course, we always individualize care, but when I talk about standardized approach, for example, one of my research project is studying how best to manage gestational diabetes. There, in fact, you would be surprised, there's no guidelines when exactly to start insulin, how many high blood sugars are needed to start insulin. And we did the research and we found that because there's no guidelines, each patient gets insulin at different time points. And we proposed this project to standardize this, to study and make sure all patients get the same treatment at the same time.
Mm-hmm. We have such an engaged group today. Would you mind if we forewent our rapid round questions so we can at least get to these last three questions, which I think are really good and will really serve for our conversation today? Do you mind if we just dive into those?
Yes, let's do it.
So this one question is, for a patient who had preeclampsia previously, are they at risk to have preeclampsia again in a subsequent pregnancy?
Yes, they are. And what's very interesting, now we know that not only they're at the risk of preeclampsia in next pregnancy, but we think that, well, no, they're at high risk of long-term heart disease, long-term chronic hypertension, infarct, heart failure, and it will happen earlier than patients that did not have preeclampsia. So we think pregnancy was like a stress test that revealed what's our body's at risk for long-term. And that's part of my research.
That's interesting. And I think the question that we asked before, like, what role does nutrition play? And you're like, when you're pregnant, you really have to focus on it. But when you talk about maternal and pre-pregnancy planning, like getting your diet and lifestyle together. So even in utero, you are eating the foods to encourage a healthy birth outcome, but also postpartum, maintaining that diet, especially if you have preeclampsia, because you're at higher risk, as you said, of heart disease and other cardiovascular challenges.
Exactly right. Exactly right.
So this next question is, how does Wisconsin compare to national statistics and disparities?
Yes, that's also a very good question. So depends what condition we'll look at. For example, if we look at preterm birth, that affects about 10% of pregnancies in the US. Wisconsin's doing okay. It's 0.1% under that. But if we look at preterm birth rate by race and ethnicity, we're one of the leading states in highest preterm birth rate among non-Hispanic Black patients. And the same if we look at infant mortality. Unfortunately, Milwaukee is one of the, it has one of the highest maternal mortality rates for Black babies. So for some conditions, we're not doing well. And for some, we compared to other states.
So this last question, I think, goes hand in hand with the doula question, but this one is asking, how do you suggest new nurses work to get new mothers to nurse and change the culture around nursing in Wisconsin?
That's a good question. So that's nurses that work in the hospital, that, or about the doulas?
It's nursing. So it's a two-part question. So the first part is, how do you suggest new nurses, like nurses new to the field, work to get the mother to nurse, as in breastfeed, and really change the culture around how nursing is seen in Wisconsin? Breastfeeding is seen in Wisconsin.
Okay, I see. So I think this effort should start earlier. Once the patient gets pregnant, already during pregnancy, we need to talk about that. The obstetric provider and the doula, if the patient has the doula, should talk about all the benefits of breastfeeding. It's not just the baby that will benefit from breastfeeding, but it also the mom will benefit from breastfeeding. I did not mention that we did not talk about breastfeeding, but for example, patients that have gestational diabetes, if they breastfeed, they have a lower risk of type 2 diabetes.
Oh, wow.
And now there's research showing if patient had preeclampsia, if she breastfeeds, lower risk of long-term chronic hypertension. So I think first educating moms. There's so much benefit to breastfeeding, both to moms and babies. Starting the conversation early during pregnancy. So that's when the patient is at the postpartum floor, it doesn't fall on the nurse suddenly to deal with that and convince the patient. And important to note, we need to have infrastructure for mom to be able to breastfeed. So longer maternity leave, making sure all workplaces have a lactation room and all the conditions for mom to take breaks and to pump if mom has to go back to work early. It's many things, again, factor into why we have low breastfeeding rates.
I mean, thank you for saying that, because I think as a mother myself, having a very short maternity leave and coming back to the workplace, even in women-led organizations, the organization I'm with now, we have lactation rooms, but at that time, 5 years ago, we didn't. And having to pump and close down the blinds in my office, it just was not a relaxing environment, which really inhibits your ability to produce milk. But I can't say enough about the benefits of having a doula, having a friend, having a supportive partner. And I'm just curious, for our audience and people who are giving birth at Froedtert and Children's, does Froedtert and Medical College of Wisconsin directly connect the trained doulas to current patients? Do they increase visibility of the resources? Like, how is that connection made now? How would someone know where to find a doula?
Yes. So by the way, we do have lactation consultants on the floor. I wish we had more, but we do have lactation consultants. And we are working now with the doulas to refer patients to doulas even during pregnancy. Because like you said, doulas will continue the support once the physician finished kind of the pregnancy care and the patient goes home and left to herself. That's really important where the doula support can happen, and especially in the breastfeeding area. Yes, we are connecting now patients to doulas to promote breastfeeding.
This has been a very fruitful and beneficial conversation for me, and from the engagement of our audience, I'm pretty sure that they've benefited from it and getting their direct questions answered. And so with that, I want to thank you, Dr. Palatnik, for joining us today, extending your expertise to us. We appreciate you really taking the time to talk with us about this very important topic. So thank you.
Thank you for inviting me.
Yes. And for those of you out there in the interwebs, if we didn't get to your question, we're so sorry, but please feel free to send us a note at conversations@mcw.edu. And folks, I hope you all join us next month for a virtual coffee break and a conversation with a scientist. Yours in health, Raina. Have a good one.